Good afternoon and welcome everyone. My name is Max Rogers. I'm the Executive Director with the Neurological Alliance of Ireland, and I'm delighted to welcome you all to the launch in CHO 5 of our Patients Deserve Better campaign. This nationwide campaign is calling for a community neurorehabilitation team in each of the 9 community health organisations areas throughout the country. And that's recommended in the 2019 implementation framework for the National Neurorehabilitation Strategy. And that strategy, that policy, as I say, published in 2019, is a commitment both in Sláinte Care and in the current programme for government. I'm delighted to see many of the 22 national neurological charities that are supporting this campaign present at this launch here this afternoon, together with local representatives. And I particularly encourage our local representatives who are on the call to introduce themselves via the chat function and let us know they're there, particularly if someone is representing a local elected representative today, just to let us know that they're being represented. I'm going to shortly hand over to our 3 speakers. But before that, I do want to say a little bit about the campaign that's brought to you by the Neurological Alliance of Ireland with the support of Roche Products Ireland. So just the first slide there, Sorka, if that's possible. We're all aware of the systemic health challenges that are facing our health system, and we hear about them all the time in the media, particularly this January. So we hear about the issues of not enough hospital beds. We hear about overcrowding in A&Es. And particularly that people's needs could be managed better in the community. It's almost like a mantra at this stage that if community services were better developed, we wouldn't see these problems year on year, which used to be in the wintertime and are now affecting our A&Es throughout the year. And in particular, you're going to hear this morning of people travelling often to major population centres like Dublin or Cork for services that should be available locally, and community neurorehabilitation teams certainly fall into that category. So the way I describe community neurorehabilitation teams for people who are unfamiliar with this service is that they are and they represent Sláinte Care in action. They're the right care in the right place at the right time. So, for example, in the whole of the Southeast, and you can see on the slide there, the counties that come under HSE CHO Area 5, there is no community neurorehabilitation team, and that is despite a clear recommendation in the implementation framework for the National Neurorehabilitation Strategy, which was published back in 2019. Professor Ronan, National Clinical Lead for Stroke, who I'll hand over to shortly, will speak of the implications of that for stroke patients. And also, following Professor Collins's talk, you'll hear from local constituents, Mary and James, living with Parkinson's disease and multiple sclerosis, and just the difference that having a community neurorehabilitation team would make to them. So just the next slide there, Sorka, if that's okay. And so again, these are some of the 22 national charities that are supporting our campaign. Each of the conditions that these charities represent would benefit from having a community neurorehabilitation team in place, which is a relatively small, multidisciplinary team that provides specialist physiotherapy, occupational therapy, neuropsychology, and other services to people with neurological conditions. And just to stress that while we do have neurology, hospital-based neurology services, albeit themselves under-resourced in the Southeast, we don't have anywhere in the Southeast a dedicated community neurorehabilitation team. So just the next slide there, please. So just as I say, there is a network of 9 community neurorehabilitation teams that were promised back in 2019. There was a team recommended for CHO 5 in the Southeast, providing this network of 9 community neurorehabilitation teams would save up to 42,000 hospital bed days each year, at a time when we're constantly hearing about the lack of hospital beds in our system. And just the final slide there, Sorka. And again, we hear so much about cost saving. For every €1 that would be spent on community neurorehabilitation services, the HSE, the health services, saves €11. And that's just from the expense of keeping people out of hospital, keeping them well, keeping them living in the community. And that's just health service spending. There is the wider saving on keeping people at work, keeping people well in their own communities. So I'm going to hand over now to Professor Ronan Collins, who's the National Clinical Lead for Stroke, and he's going to speak about the particular importance of these community neurorehabilitation teams for stroke patients in its role as National Clinical Lead, but also more generally for neurological patients in the South East.
Thank you very much indeed, Mags, for the kind introduction. And let me say at the outset that the National Clinical Programme on Stroke, and indeed myself personally, are fully behind this campaign that patients do deserve better with neurological illness. Stroke as one of the neurological illnesses is a good template by which we might lever off in some respects. Because many of the principles that we are trying to put forward and to establish within our healthcare structures are mirrored within the stroke strategy. And I will share a little bit of that with colleagues during the talk. But I wanted to chat principally about, to give you some examples of why this is so important. And if we take stroke as the commonest cause of acquired neurological disability, it's not a competition, but it just happens to be the commonest cause of acquired neurological disability in adults. We would know, for example, that 72% of stroke patients leave hospital with some form of disability or physical impairment, and over half of those have moderate to severe physical impairment, as shown in the modified Rankin scale. And so you can see of what is one of our commonest acute neurological conditions, that even that in itself creates a huge patient need and challenge for us within the health service, but also on a more fundamental level, displays to us also how many people must be out there living difficult lives with inadequate support and community-based rehabilitation services. It is often quoted, for example, that there may be 30,000 people living with physical impairment and some form of disability after a stroke. But that is based on very old and outdated kind of estimations of what the burden must be. And if we certainly look at our population growth and you take standardized figures for incidence and prevalence of stroke from the UK, we reckon there must be at least 90,000 people in Ireland living in the community with physical impairment after stroke. And one of our calls within the strategy, and I know the Irish Heart Foundation have joined us in this, is to get up-to-date information on how many people are living with physical impairment after stroke in the community. I'm aware that stroke is just one of many neurological conditions, and as a geriatrician, I'm aware of a lot and look after patients with those conditions. Most, or at least many, of the neurological conditions are age-related, but not exclusively so, and the stroke program recognizes that as well. But to use that as a template, as I said, if you go back to intracerebral hemorrhage, for example, only 8% of patients with intracerebral hemorrhage will leave hospital with no disability. And so there is a crying need and indeed a human right for patients who are living with neurological illnesses to have proper supports in the community. We must also recognize, no more than we have recognized in stroke, that while there may be an acute component to this, and even an acute deterioration in many of the neurological conditions, that there must be a commitment to people who have neurological illness under a chronic disease management program that recognizes their right to be supported in the community, to live at home in the community with quality of life. And that is something that we must all uphold for our patients who have neurological illness. Unfortunately, I'm long enough around to realize how many reports we've had about this. I can go back probably to the first report I remember myself, my professional life, in 1998, years ahead, which looked at the issue of rehabilitation for older people and recognizing the demography that was going ahead, that was going to happen, and we need to have proper resources. There then followed a national strategy and policy for neurorehabilitation services, first iterated in 2011, followed by a specialist model of geriatric medical care in 2012, followed by a model of neurorehabilitation care published in 2019, as Mags has alluded to. None of these reports have been fulfilled. And we have to ask ourselves, why is it that some of the most vulnerable people in our society who are struggling to live in the community, despite the recognition of healthcare professionals that we must have better services for patients, why this goes unheard by the political body. And in that regard, I personally really welcome this initiative because we do need to shout a bit more on behalf of people. Patients do deserve better to live their lives at home with quality, and also their families deserve the support in order to continue family life in the midst of the challenge of what is neurological disease. I wanted to share a couple of slides if possible. I'm hoping this is going to work. I have mixed experience with this myself in the past, so I'll give it a go, but I think it is going to work. And I wanted to point something out, and this is just a template. And I want to share this importantly because, again, like the National Model for Neurorehabilitation, this is in the programme for government. It has the support of the executive management team of the HSE, and so we must make sure that when our policies do get that support, that we actually follow through and call our politicians to task and say, have you implemented it? Have you given us an implementation framework? Can we see the deadlines? And can we get a progress update into how you're doing? And I think we need to get more focused in calling people to task. But anyway, this is our national stroke strategy. And I want you to direct you, if you take online, we have a specific pillar of our stroke strategy in terms of rehabilitation and restoration to living. I think we really were keen to include the term restoration to living because we want people back living, enjoying their lives, getting quality from their lives. And rehabilitation must mean that as well, and not just a short-term commitment to getting people out of hospital. And I think that is something also that we need to stand over. You will see that we recognize the rights of people to core principles. We're also aware within the stroke strategy that there are dual strategies out here. And a challenge for us within the Neurological Alliance of Ireland and patient advocacy groups is to ensure that we speak the same language, and that the models of care and reports are out there are dovetailed so that we're not going to ask for duplication of services. We have within the stroke strategy outlined the current available strategies and also what the model looks like, and also given a commitment that rehabilitation should reflect national and international best practice, and that there must be a commitment lifelong. We all know that we've inadequate neurorehabilitation services. We all know that we need at least 300 more neurorehabilitation beds for the expansion in our population. And while we have taken the first tentative steps, and I'm aware of my own unit, for example, or my colleagues' unit in Piedmont is a step forward, there is much more to be done, as this conference and symposium is highlighting, for example, in the Southeast. And so just to say as well that we are fully committed in the stroke programme, and that, as it's mentioned there in the early supported discharge is just the first contact in transitioning what we see as our specialist model of care to get patients transition successfully to home, but that does not take the place of a proper neurorehabilitation model of care. As I said to you, almost 2/3 of patients leaving hospital with stroke will have some form of moderate severe physical impairment, which will need proper resourcing and a commitment lifelong going forward. So I would like people to not see the stroke strategy as the panacea for everybody's problems, but rather officially reinforcing what the NAI message is here, that there needs to be a commitment to people living in the community with neurological conditions and physical impairment. And on that note, I want to thank you for arranging this important conference and symposium and highlighting the issue. And I hope this is going to be the first of many roadshows to start increasing public awareness about this.
Thank you so much, Professor Collins. And it's just heartening from this campaign to see that so many clinicians from different specialties, from stroke, from neurology, from rehabilitation medicine, are coming together behind this campaign. And just if people caught that slide earlier on, with 22 national charities coming on message, calling for one initiative. And I would just stress to our elected representatives who are on the call this afternoon of just the difference having a community neurorehabilitation team in place would make to the lives of people with neurological conditions living in the southeast of the country. And I want to hand over to our next speaker, James Flanagan, who is a person living with multiple sclerosis in the southeast. And he's going to talk about his own experience and just the difference having a local community neurorehabilitation team would make to him.
Hi, Mags. Hi, everyone. So as Meg said, I'm an MS sufferer myself. My name is James Flanagan. I'm from Tipperary. I had first diagnosed with MS in 2014. I have the version of MS called, I suppose, it's secondary progressive relapse remitting MS. My current circumstances with MS means that I have to use a crutch, and I'm fairly, I suppose, very limited walking ability. I'm down to about maybe 2,000 steps per day. So quite a low step count. And that is gradually getting smaller and smaller as the days go by. I am doing my best to try and keep it up, but it's an ongoing struggle. So my local services that are available to me here, I suppose in Tipperary, I live near Cashel. Cashel has a primary care service. I do avail of that. I get physio there. But the physiotherapist that I see in Cashel would be the same physiotherapist that would deal with a sprained ankle. I have a chronic serious condition, and I just feel like that I'm not getting the treatment that could really help me from someone or a unit that has a special ability to deal with people who have a neurological condition. So just a bit more on my disease and how I was treated with it. There last year, I went through AHSCT, which is stem cell therapy in the UK. I received, the treatment was paid for by the HSE through the treatment abroad scheme. Cost over €90,000, I'm sure, and I probably spent €10,000 of my own money between accommodation, this and that. But once the treatment was done in the UK, I came back to Ireland and there was no follow-up. There was no rehabilitation. There was no rehabilitation, but there was, in particular, there was no physical neuro rehabilitation, which I think is a massive missed opportunity because we spent so much money. I say we're taxpayers, we're all part of this. We spent so much money on me getting this treatment, and then we completely dropped the ball when I got back. Now, I did my best to keep cycling, keep walking, but it's slipping all the time. I'm not a specialist in physiotherapy, and I'm certainly not a specialist in neurophysical physical therapy. But yeah, that felt like a savage missed opportunity. But I was following up with my my neurologist, and I was asking for. I basically sat down myself and I figured out. My neurologist was telling me, "Well, James, your MRI scans are not getting worse, so you shouldn't be getting worse." Well, I felt worse. I said, well, if my MRI scans are not getting worse and I feel worse, well, maybe there's a way I can get it back because I shouldn't be. It's just maybe it's muscle degeneration. And I asked, can I be admitted into some rehabilitation unit? And I had heard nothing about neurorehabilitation, but I figured it out my own. This is what I need. And thankfully, my neurologist is absolutely brilliant. Dr. Karen O'Connell in Carlow University, she mentioned that she would be able to get me a bed in Peamount in Dublin, near Newcastle, and for me to be assessed and go through some neuro rehabilitation. Now, this was, I suppose, last October, and Karen thankfully got me a bed only a couple of months later, but with college and everything else that I'm doing at the moment in the University of Limerick, I just wasn't able to go there. I said, look, can we go in January? No problem. They called me back in January. But as you know now, we have a massive crisis in the public hospitals, and I'm being pushed out. I'm being like they're making the bed that was available to me. I think it was the 16th of January. And just there last week as well, it was available to me. Can I get a call? No, James, all these beds are being taken for the public sector to get people from the emergency wards. So like I'm being pushed down the line and being like just basically told to stay at home, cast aside. But my condition is degenerative. So every day that goes by, like I said, my step count goes down and goes down and goes down. And I'm here waiting to be admitted to physical rehabilitation. And literally, I don't know how much there will be left to rehabilitate by the time they take me in. So I'd be thankful to get there when it does eventually happen and the emergencies are cleared, the newspapers and the headlines are all cleared. But I'll still be here with a serious condition and no rehabilitation. So the sooner that happens, the better. I suppose just on Peamount, the service itself, I live in Tipperary, like I said, near Cashel, between Thurles and Cashel, and it's 140 kilometres for me to get to Peamount. 140 kilometres. Now, like I said, I can't walk very far. So I'm looking on Google Maps to see how far is the car park from Peamount. Can I walk in? How am I going to get there? Like, I'm worried about this. Like, I'm working a full-time job down here in Shannon Airport. I'm in Shannon today. I'm working down here. I can just about get down here, get through my job, and get home. But now I have to figure out how I'm going to even get to a rehabilitation centre. It just seems like really unfair to put people in a very vulnerable position through even more difficulty, and it just seems unnecessary. Like, it seems unfair. And like you said, there is a commitment there to put neurorehabilitation centres in the community. I can say I am absolutely looking forward to the day that I don't have to travel 140 kilometres to see a specialist neuro physiotherapist. It would be absolutely fantastic. But yeah, that's pretty much my story. I need to be honest. No, that's pretty much it. I suppose, like, unless you have any questions for me, Mags, I think that's all I needed to say.
James, that's a powerful testimony. You know, I'd say you were willing to travel that distance to get rehabilitation. You shouldn't have had to travel that distance, but you were willing to do it. And then, as I say, you had the disappointment recently that because of the overcrowding crisis. And just to say, I mean, what we're looking for, James, for the Southeast is something that's available in other parts of the country. There are community neurorehabilitation teams set up and working in Limerick and in Donegal. They work extremely well. We had a presentation from them recently. When the service is available, it makes such a difference. It makes such a difference to the local hospitals, to the local people living with neurological conditions. And you referred to it, James, to the primary care staff who have, at the end of a phone, they have access to that specialist expertise. So they can ring the specialist neuro physiotherapist in the team and get advice from her or him or her on how to meet your needs. So look, I think you've given a fantastic testimony today to your own experience of just that difference it would make to you to have that service available locally. So thank you so much. I just want to bring Mary in. Mary, again, living with a neurological condition in the Southeast. And just, Mary, if you can talk about your own experiences.
Yes, thanks very much, Mag, and thanks for everyone here turning up today. It's something I feel very strongly about, to have neurorehabilitation available to everybody in Ireland, and particularly in CHO 5. I'm living with Parkinson's, and I'm also chairperson of early onset Parkinson's disease. I was diagnosed 4.5 years ago at the age of 53. But I had symptoms for many years, and I was told I had essential tremor or fibromyalgia. So when I got the diagnosis of Parkinson's, it was a relief to know what it was, but I was really shocked because I didn't know anybody my age. I had an uncle in his late 80s who passed away a month after I was diagnosed, which was quite hard on my two sons to see what he went through. But so then I was even more shocked to be told to come back in 6 months. That there was nowhere to go. If I'd had a heart attack, I would be sent on a 6 weeks cardiac rehab course. So I had no information on how to manage this disease and what to do. So I went onto the internet, which I can only describe as scary and depressing. Like, you have to go through so much information to try and find out what's relevant to you at this stage of the disease and your age. So that was quite daunting. And I was also having balance problems. I didn't know why I was struggling to go upstairs, why I was suddenly standing in a supermarket and wobble, that people might think I was drunk. I didn't know that exercise could help that. So it was just lack of information and how to manage this disease. which I'm going to have to live with for the next 20, 30 odd years, and everybody with early onset Parkinson's. So it's quite different to know how to manage this. And I was on the call there a few weeks ago, and I seen what Limerick are doing with this neurorehabilitation, and that would be just like winning the lotto for me if I had that when I was diagnosed, because you need the assessment of everybody is so different with Parkinson's. There's about 40 different symptoms. It affects everybody differently, and you need a proper neuro assessment from a physio to know exactly what your problems are and how to rectify it. Like people would say to me, when do I start exercising? You start exercising on day one, but people don't have that information, and you need to be empowered to know how to manage this disease. Also, speech therapy is very important. Like people don't, if you're visiting your consultant, they mightn't pick up on it in 20 minutes that you're having speech problems. You mightn't even know yourself that this is a sign of your speech is deteriorating with Parkinson's. And speech is so important. If you can't be understood or heard, you stop socializing. So that has an effect on your mental health. And also I was working, and I love my job. I had quite a responsible job, but due to pain, I had to give it up. So I didn't know there was help there for an OT assessment, assist with technology, work adaptation grants. So that was two kind of life-altering situations I was faced with in 1 year, and with no help. So I think it's good to see that the psychological support as well. I think that's often overlooked when you're diagnosed with a neurological conditions. It's like, because you have to tell people, so you have to be strong in yourself to tell people, because people's reactions, you have to deal with that. Some people could say, oh, you're lucky it's not cancer, but that doesn't, sometimes cancers have been cured. Parkinson's has no cure, and it is progressive, so people don't understand the disease, so you have to explain. And also they say, oh, you're too young to get Parkinson's, so you have to be very strong and be able to deal with the diagnosis yourself before you can tell others, and it can take a while for people to do that. I've spoke to people who they could be 6 years diagnosed and still struggle to say the word Parkinson's. So I think sometimes the psychological effect of being diagnosed with a long-term progressive disease with no cure is often overlooked. So like this, we just need this so badly in the community, and it shouldn't be, that determined how well your outcome of this disease as to where you live. It should be accessible to everybody, to manage this disease. Also, I just wanted to say that we need some place to go. We need advice. We need information. And Parkinson's, unfortunately, is the fastest growing neurological disease in the world. So we need to act now to implement these. Now, the pandemic came. It wasn't expected, but we're saying here today that this is coming down the road. It's really growing fast, and we need intervention now. The hospitals are already under pressure. If we're not getting the help, to manage, say, balance exercise, prevent falls, speech therapy, swallow problems. If we don't get early intervention, it's very hard to get back what you've already lost. So we need intervention. Early intervention is key. And we want to be, the campaign is patients deserve better. We don't want to be patients. We want to stay out of the hospital system. We want to be empowered to live well in the community as well as we can with this disease. And so I'm pleading with the government and the powers that be to really put this in place, that this is a brilliant initiative, and that's what we need in the community, and not to have to travel, because it's just not possible when you're unwell to travel distances to get services that you need. So I really am really behind this campaign. I think it's great for the NAI to have started this campaign this year, because it's something that's really close to my heart, and I just see in the community of what it could do and how it could really help people. So that's my story today. Thank you.
Thank you so much, Mary, for bringing us through that, and to say the bravery of the people on our call today that are stepping up above the parapet and talking about their experience of being diagnosed and living with the neurological condition. And I suppose just to reiterate and go over some of the messages that you've heard this afternoon, a community neurorehabilitation team has been promised for the Southeast for CHO Area 5. It was promised back in 2019. along with a community neuro rehab team in each of the 9 CHOs around the country. The South East has neurology services, albeit they are under-resourced, but we do have neurology services in the local hospitals in Waterford and Kilkenny. But we don't have a community neurorehabilitation team to support those neurology services, to support people living with stroke, with Parkinson's disease, multiple sclerosis, a wide range of neurological conditions. And we've heard James's experience of being willing to travel to Dublin, to take time out of work and travel to Dublin to get access to specialist neurorehabilitation. He shouldn't have to do that. Professor Collins has just said the multiple policies down through the years that have recommended these community neurorehabilitation teams. I'm just going to hark back just to show everyone the 22 organisations that are supporting this campaign. Just if you have that slide there, Sorka or Emily. Just so you can see clearly the range of national neurological charities that are supporting Patients Deserve Better. We will be continuing to campaign throughout the South East and also throughout the country. We'll shortly be organising an AV room presentation in Leinster House during March. Our next launch will be in Cork in a couple of weeks' time. We'll be taking this campaign nationwide. But just with that message in the South East, a community neurorehabilitation team has been promised. And this campaign will be, as I say, it will be led by the 22 organisations that you see in front of you here, and you've heard from local constituents this afternoon of the urgent need for a community neurorehabilitation team for the South East. I just want to offer any of the elected representatives, I suppose, give them a chance to come in if they have any particular questions around the campaign or around the work of community neurorehabilitation teams, just if they want to join in. I don't think we've any questions there. Just thank you to those who have introduced themselves on the chat. Okay, so look, I'd like to hugely thank our speakers here today. I think they've given a really, really powerful testimony of the experience of living with a neurological condition in the South East. Professor Collins has outlined how this is an issue for stroke, but not just stroke, for other neurological conditions. It makes sense. It's been constantly reiterated in our health policy that we need to be putting more resources into the community. And this, as I say, the community neurorehabilitation teams are exactly that. They're keeping people out of hospitals. They're keeping people living well with neurological conditions. They are a simple, cost-effective measure that makes such a difference to the lives of thousands of people living with neurological conditions in the South East. So we will be following up with the elected representatives that are on the call this afternoon for those that could not attend, and calling for their support for establishing and funding a community neurorehabilitation team in the South East. Thank you all for coming.